Hello, I'm back again on the stage for the third time today. Second was, of course, impromptu, thanks to Neeraj, yes. But definitely very, very happy to be here. Eye-opening session, Dr. Rajagopal, also known as the father of palliative care in India, and very much so. For 25 plus years, he's carried the torch, he's brought in legislation, he's pushed a lot of youngsters to get into the field. He's convinced the state government to implement palliative care policies. And yes, the journey is not yet done, and he's still fighting a battle which we hope more warriors will join. A big round of applause to Dr. Rajagopal, sir. What was the most eye-opening sentence that he said? Palliative care, more than physical suffering, is emotional suffering. And as doctors, and particularly my specialty, which is more critical, it's emergency medicine, we are running behind physical therapies much more than we are running behind emotional therapies. We want to use our medicines and drugs to relieve the suffering, but can we do the same with our words and thoughts and what we build as a care plan for them? Was very, very eye-opening for me. So I'm very excited to go into the next panel discussion with expert panelists who are going to join us on stage and take this discussion forward with the human work that they are also doing in this field. My first panelist on this session is Dr. Mathews Numpeli. Dr. Mathews Numpeli, please come on the stage. I request you to please join us on stage. As he comes, let me introduce him. A big round of applause for him if you want to. Please don't be shy with the applauses. Dr. Mathews Numpeli, presently working as a medical officer in charge of Family Health Centre, Ayampura, Ernakulam district in Kerala, also serves as the state-level executive committee member of Ardram Mission of Government of Kerala, which is involved in palliative care activities of the state since 2000. He also works as the convener of state working group on palliative care. So to give us the government side of things, he's the perfect panelist to be here, Dr. Mathews Numpeli. Thank you. Thank you so much for joining us on stage. Our next panelist, Ms. Neha Sinha, is the co-founder and CEO of Epoch Elder Care. Epoch Elder Care runs assisted living homes for elders with specialized care needs, with a special focus on dementia and other neurodegenerative conditions. As a dementia specialist, Neha has gained international recognition for developing dementia services in India. She has a background in clinical psychology and training in palliative care philosophy from Sophia Hemmet University, Stockholm, and brings a unique perspective to elder care. The Epoch model of dementia care follows a person-centered approach while focusing on overall well-being and happiness, and I'm sure she'll tell us more about it as we go through. They operate about 6 assisted living centers today in Gurgaon and Pune. Some of the awards that she's won: BW Healthcare World 40 Under 40 Award 2022, featured in Forbes 30 Under 30 Asia list 2016, CMO Asia's North India Women Leader 2021 Award, board member of the Association of Senior Living, Advika National Award for Women Achievers 2023, and advisor, Dementia India Alliance, Mrs. Neha Sinha. Please, ladies and gentlemen. And our third and final panelist of the day, Dr. Dhvani Mehta, is co-founder of the Vidhi Center for Legal Policy, an independent think tank based in New Delhi, Bengaluru, and Mumbai, that does legal research to make better laws and improve governance for the public good. She leads the organization's work on health and medical law with a special focus on end-of-life care and palliative care. She appeared in the Supreme Court in 2018 and in 2023 in Common Cause versus Union of India, supporting the legislation of advanced medical directives and later petitioning for the simplification of this process laid down by the court for the withholding and withdrawal of life-sustaining treatment. She was also part of an expert committee of the Indian Council of Medical Research that developed guidelines for DNR, that's do not attempt resuscitation, and has assisted AIIMS Delhi, Kasturba Hospital Manipal, Sir Gangaram Hospital Delhi, and Tata Memorial Hospital Mumbai with developing the internal protocols for end-of-life care. Together with her colleagues at Vidhi, she has developed a ready reckoner and toolkit that answers frequently asked questions about the legal framework on end-of-life care as well as a sample advanced medical directive. Dr. Dhvani Mehta, ladies and gentlemen. And I'm going to join them right away. Thank you, wonderful panelists. The clock's ticking. So let me get right to the meat of the matter. As an emergency physician, one of my biggest pain points was withholding care. People coming in telling, they are not sure where that brain hemorrhage is going to land up, where that head injury patient is then going to, whether they're going to recover or not, how long do I put them on a ventilator. They want to take their family member and spend time with the family, holding a hand, like Professor Rajagopal, Dr. Rajagopal told us. They want to do that. But for me, that's a gray area. I'm not comfortable in that gray area. I'm not sure what is the guideline I can give. I am working in curative care. I'm not working in palliative care. How can I better equip myself to advise them? What is the support system that exists for them to go? What are the guidelines or legal repercussions I may face as a doctor or a healthcare provider? What support systems does the government or non-government organizations have? A lot of questions about palliative care, and today my eyes have been opened where palliative care is not just end-of-life care, it is about relieving suffering for anyone who has a chronic health condition that doesn't allow them to have a great quality of life, right? So it's a pleasure to have all of you here. I'm going to start off with Dr. Mathews and ask him a question. Can you please explain to us the work, the amazing work that you're doing with the Kerala state government? Please give us an eye-opener to it.
Thank you for inviting me. As per WHO definition, palliative care is for all people with serious health-related suffering. Also, we'll have to start palliative care right from the start of the suffering. As per this definition, the patients, if we count the patients admitted in the government and private hospitals of India, at least half of the patients are in need of palliative care at any point of time, in some way or other. So, we will have to address it. The palliative care is defined as physical, psychological, social, and spiritual support. Health professionals know only the physical part. So, the major component will be unaddressed if it is done by professionals, health professionals. The only alternate option is to engage the community, to make it as a community-led program. What we did in Kerala was we went into the community, we sit with the community and empowered the community to identify the health-related suffering in their area. Because people know who all are suffering. They know that they may not be knowing the name of the disease, but they know that such and such persons in their community are suffering. They also want to do something to relieve that suffering. They are doing it in the way they can. But that's the catch. If professionals can go to the community and help the community to do in a better way, the program will succeed. So, in Kerala, the professionals went into the community, identified the suffering, and see how community is trying to solve that, and we added on the medical and nursing part to that community. For that, we have a system of addressing the suffering, such that the community can identify who all are suffering based on their mobility and disease status. So there are some persons who need support to get up from their bed, maybe due to any reason. That we call them mostly as bedbound. The percentage is 0.7% of the total population is bedbound. That means 70 per 10,000. That is about 200 per 30,000 population. That's the population of one panchayat. So there are 200 persons in every panchayat who are bedbound, who need support to get up from their bed. Also, the homebound people, that means people who need support to get out of their house. It's about 1.4%. So both this category itself comes to around 400 to 500 per 30,000 population. So what we did was we started a home care program to address these issues, because sitting in a hospital, we cannot prioritize this issue. We cannot identify the issues of the patients. We will have to go to their house, see the patient and relatives in their surrounding, and see what all they are doing, what they need. that assessment has to be done. That can be done only at home. For that, we started home care service. So Kerala appointed one nurse in each panchayat to go to each patient's house. That's sir said every blood-bound patient is being visited by the nurse at least once in a month. During that visit, this nurse sees the patient, she observes it, she identify the needs, she prepare a case sheet, and she empowered the family to care the patient in a better way. And we supply the materials needed for the patient, and medicines which are supplied, which can be supplied by the hospital, are also given. Comfort devices are being given, and the community also is supporting in all this process to do it in a better way. So that community-based approach is the key for success of the palliative care program in Kerala.
Fantastic. A big round of applause for the Kerala government for doing that, please. Sir, please hold the mic. I have curiosity, and I'm going to quickly follow up before I move on to other panelists. When you go into the community and tell them, you know what, you have to start taking care of this person. Like, I mean, 400, 500 people around us in our locality are bedbound or need help with activities of daily life. Me as a community member, do I have resistance to it? Am I willing to do it? Have you faced this kind of a problem? Is the community always willing to help?
Because every person want to help others. That's the basic, because we are living because of that. We are living every day with the help, support of many persons. If some person is in suffering, there are many persons in their surrounding. Their family is definitely is there, and their friends are there, their neighbors are there. There are some persons who are ready to help this family to relieve their suffering. So we'll have to just join hands with the team around the patient to make them do it in a better way.
Fantastic. Thank you so much, sir. I'm going to move to Neha before I come to Dr. Dhvani. Neha, we talked about the community, and in particular, Dr. Mathews was outside the healthcare community. Now, Epoch Elder Care works in that sphere, right? Can you explain to us the work that you do and how you're assisting people who need help, who are unable to get things done by themselves? Please explain to us.
Sure. Thanks. Thanks for having me here. So, I was just wondering, and I was listening to this absolutely wonderful talk that we just, had from, Dr. Rajgopalan, and I realized how my journey into palliative care began is, when I started Epoch, I was, in my 20s, and one of the things that I really struggled with because I had not seen it, I had not experienced is, we are standing in the middle as Epoch or as care providers between the physician and between the elder and the family, right? So we are between, four people. And I struggled to, kind of guide my team on what is the right positioning, because there are not necessarily ethical frameworks that are available readily or awareness available on what is the right thing. And that's when I did a specialization and got a certification in palliative care ethics. So there are two situations when somebody would come for palliative care in an Epoch home. One is when they have stayed with us and they have deteriorated because their condition has progressed or a comorbidity has come in and obviously they have deteriorated, and the care plan moves from an assisted living or a dementia care plan to a palliative care one. And the nursing team identifies that and then has the tough conversation first with the family. The other is when they reach out to us when they are at the fag end of the illness, when it has become so critical that they need that sort of help. And why would they come to a care home at this stage is we have often seen is because either they've gone through a long caregiving journey and they're really, really tired and they don't want to, they need help to do the last run in a sort of way. And the other thing is when they want that everything should be perfect. I want my mom to have the best possible care. There's always this sense of hope that something could be done. And that is a problem, by the way, which happens more with people who are resourceful and affluent. And they always think that maybe, money can be an option, but sadly it's not. So Epoch comes in between where we take the responsibility, and it's a lot of expectation and pressure situation where, let's say there's a 95-year-old who is, obviously immobile, advanced stage of dementia, and there's respiratory distress, and the hospital would want to intubate them. And that's when the question comes that, why would you want to do that? are you sure that it's going to add quality of life? And the family here in that moment is extremely emotional. It's not an easy decision when the doctor says, for whatever reason, that they need intubation. And there we need to sit down, and it is a very, very emotional situation where you need to be professional yet empathetic, yet convince the doctor, and kind of move the care plan into a palliative one. Sometimes we have to take a llama and get them back to an Epoch home from a hospital ICU and tell them that they need to pass away, if not in their home, the next home, which was Epoch for the last couple of years. So our work is largely around managing families as much as managing elders. And for elders, we have a framework. There are many frameworks, but the one that we use is very simple. So we focus on psychological, physical, social, and spiritual. So these are the 4 aspects that the care plan needs to have as care goals. And our nursing team will ensure that if there is any possibility of us knowing that the elder wanted to pass away in this manner, or go back to their home sometimes, or visit a particular place, meet with some family, we will make that happen.
Fantastic. When you were saying doctor wants to intubate, I was thinking I am the doctor. But yes. So I'm amazed that you are able to have parallel conversations with the family as well as the healthcare provider and convince them both. How difficult or easy is that conversation? Because obviously, I know as a doctor, my ego is going to be hitting the roof and I'm going to need a lot of convincing. And family, their emotions are going to be hitting the roof. And then that has to be managed very effectively. How do you get around that? How difficult? I'm sure it's difficult. I can't even ask you how easy it is. That would be insane. But
so a lot depends. I think I'm blessed to have a fantastic nursing team, and a lot depends on whether the doctor really understands the work that we have done. So it's not going to, it has to come from a place of credibility, one, because obviously doctors listening to nurses is a tough one, but that happens, and I have seen that across my homes, across hospitals. We've gone there and explained that, doctor, please. And also doing a DNR is not, there's no black and white on how you take a DNR. And a lot of our family members, by the way, who live overseas, and they experience palliative care differently over there. So it's a patient right. So they will send us an email, okay, the elder needs, my mom needs to be on a DNR. As an assisted living home, I can't take that instruction, right? And sometimes if I tell the facility physician, neither can he. So it's a complex situation, and I'm so glad that, you're here to, kind of advise us on this, but throw some light rather. So it is a legal question as much. It is difficult, but it's not impossible. And we have done it many a times when we have told the family that we can do the discharge, and that's when the family goes into a, almost like a, they are like paralyzed mentally and they can't think. So that's the thinking that we need to do, because it needs to be clear thinking. And you have to do it with data and facts as much as emotions.
fantastic. And that's a brilliant lead in for us to go to Dr. Dhvani. As much as it's a moral and ethical dilemma for every healthcare provider to withhold care, it's also the legal concern that's there. So, Dr. Dhvani, please tell us the work that you've been doing and how and where we stand with this aspect today.
Sure, thank you. And unfortunately, it shouldn't be a legal question. So I shouldn't actually be on this panel. I feel like an imposter, and I think the work that I do is to try and minimize the role that the law has to play in this process. I mean, by a combination of circumstances, some unfortunate judicial reasoning, I think a surrendering by the medical profession of certain ground to the law, we have reached a situation where questions like this, can I have a DNR? Can I refuse to intubate a patient? Do I discharge someone against medical advice? These have become legal questions when the primary question should really be, what is it that is the ethically responsible, moral, humane thing to do that, medicine also prescribes. So, Dr. Rajgopal spoke about how we've lost perspective of who the human being or the person is behind the body. And I'd say that there's another layer. We've forgotten what medicine is behind the text of the law. And, I have this very complicated text up here for you. I mean, it's hard enough for me to understand. So I don't know how doctors and nurses and other healthcare workers and patients and caregivers who are at a very difficult and emotional time in their lives are expected to follow this very complicated process before deciding whether to withhold or withdraw medical care. So, I mean, very briefly, what our Supreme Court currently says is that if you do want to withhold or withdraw life support in a person who doesn't have decision making capacity, at a minimum, you need 6 doctors and you need to send a letter to the judicial magistrate, whoever they may be. Now, that's the process that you have to follow. It's unprecedented, as a matter of course, when what is involved is withholding and withdrawal. So this brings me to another point that, is part of my job at Vidhi and working with other experts in this field, is to convince everyone that what this is not assisted dying. It is not suicide. I mean, it's not assisted suicide. It's not euthanasia. And the reason for having to convince people of that is because they have very different legal connotations. Assisted dying is not legal in India. Euthanasia is not legal, and it won't be until there is legislation to support it, as you've seen is recently happening in the UK and obviously exists in a few other Western European countries and some states in the US. But this, withholding or withdrawing care when that care is providing, is causing more harm than benefit, is disproportionate, is care that the patient didn't want and had earlier expressed a desire not to receive, is actually just an extension of a patient's right to autonomy and a doctor's duty, again, as Dr. Rajgopal said, to primarily relieve suffering. It is not, doctors are not under a legal duty to provide treatment that is not in their patient's best interest. So, as much as it is about doing what you can to save the patient, it's also knowing when to stop. And these are all fundamental legal principles that exist. But again, we lose sight of them because of the complex process that has been set up and which leads to all the kinds of questions that Neha just mentioned. These are very valid ones. Oh, what do I do if a son in the US is telling me to do something and the daughter here is telling me to do something else? As a doctor, who do I listen to? Am I legally liable if I follow one person's advice and not another's? Or, what do I do if this person wants to be discharged against medical advice? I mean, why do we need a discharge against medical advice if as a doctor you think that this is treatment that is not in the patient's best interests? They should be discharged upon request and comfortably released to a place like Epoch where their goals of care can be continued. But again, unfortunately, because of this this ghost of legal liability that hovers over the minds of doctors, and I mean, I'm not blaming the medical profession at all for this. There is a problem with the way in which the law has developed, and these are valid concerns that doctors have. Unfortunately, we are in a situation where we're constantly debating this kind of legal minutiae while losing sight of the fundamental constitutional principles. There is a right to die with dignity. There is a right to make an advance medical directive where you can say whether you don't want to receive certain kinds of treatment. There is a right not to be subjected to disproportionate treatment. But unfortunately, these are not understood well by lawyers and lawmakers, and my primary job is to try and simplify that and minimize the role of the law to a safeguarding one.
Fantastic. These are the exact conundrums we face. I was lucky enough to work along with Dr. Prabdeep Kaur at a hospital which did give discharge at request along with Dharma. So our grounding in medicine was quite right. But what is the status of advanced medical directives today? What is the status of getting a do not resuscitate signature from the family? What is the status of that in India? Because we still do that today.
So the very simple answer to that is it's perfectly legal. So executing an advanced medical directive is your right. It's an extension of your right to die with dignity. There is a process for how you execute that, and of course, I can go. I can provide the audience with resources or links to that later, or answer questions on that in the Q&A section. But as a document, it's a legally valid document. If doctors are made aware of the existence of this kind of document, they should pay heed to it and try and implement it in accordance with the process that we currently have. The same goes for a DNR. It's merely a form of recording that you are going to withhold a certain kind of life support, specifically CPR. So again, if this is documented, there is a process of shared decision making between the treating team and the caregivers. You're absolutely at liberty to go ahead and implement that.
And this will be acceptable in the court of law.
Yes, absolutely.
Fantastic. Okay. Right. Okay. Let's go on to Dr. Mathews, back to him. Sir, I'm amazed that Kerala is doing such yeoman work. What I want to know is, why was Kerala the first state to support it? Why did they get into it? What is the coverage that the state government is currently providing? How many people are you now covering under the palliative care program? And once you answer that, I'd like to know, how can we expand it? What do we need to convince other governments about it?
The first question, about 90% of the blood-bound patients is being covered by the palliative care system in Kerala now. Not blood-bound, but having serious health-related suffering, that much coverage is not there. Less than 50% coverage may be there. We'll have to improve. We'll have to still improve on that. To take it to the other parts of India, my sincere opinion is, I have a difference of opinion with Dr. Raja Obal. We'll have to definitely go out of the halo of cancer, morphine, advanced medical directory, etc. Because all these are highly professional things. These need doctors. And doctors are busy with the treating patients, and they are not going to change. Now, that we definitely know. But people are suffering in the community. There are many ways to address that suffering. Because the first category, the blood-bound patients, their suffering is based on the mobility. They cannot move. They may develop pressure sore. They need head-to-foot care. They need bowel care. They need bladder care. They need nutrition. There are many simple methods to provide that in the community. They are doing it. The healthcare sector can improve that. So we'll have to change the perspective. Kerala has done this only because Kerala has done in a different way. That's why it is implemented in a different way. Out of the 2,000 units of palliative care units in Kerala, only 500 has doctors. 1,500 units are being led by nurses. They are not having that. Nurses are leading the program. They are doing all these kind of activities. Even ascites tapping is being done at home by the nurses. And most of the patients, and they are considered as doctors by the, because for common people, whoever relieve their suffering is a doctor. Because they are in that concept. But we are not deprofessionalizing care, but we'll have to make it community oriented. Then only it will succeed. So in India, there is one ASA per 1,000 population. She is visiting the houses, that 1,000. So we can easily identify the bed-bound patients and patients with suffering there. If it properly teach ASA, they can teach good skin care, wound care. She can teach basic mobility, physiotherapy, etc. There is one CHO, Community Health Officer, for 5,000 population in India. They can also have field visit. They can also address this issue. So there is enough personnel there, but we allow to reorient palliative care to make it community oriented. So community has many ways to address the suffering. The suffering means physical, psychological, social, and spiritual. Out of this, morphine and this advanced directive is only for a few patients. All the rest, the basic things, those who are not having any difference of opinion. The basic, is there any difference of opinion? There is no difference of opinion. Everyone can do it. Only thing is, we'll have to teach them, we'll have to teach the family that it is important. We'll have to empower the family, we'll have to provide the materials, we will have to give the comfort devices. That's the only thing. So that's my answer.
Fantastic. But why are then other governments not taking it up? Has the Kerala
It's up
government?
to that government, because how this can, Kerala has done only because Kerala has changed this idea from cancer and morphine to the basic care of the patient, basic suffering of the patient.
Right. Can Kerala become the champion of this and talk to the other governments? Is that possible?
It's possible, but no government is thinking like that. They are still held upon morphine and cancer.
Fantastic. All right. Let's go back to Neha. Neha, now we talked about how you have to convince doctors and families. It's not an easy job. Tell us about, from the viewpoint of the caregiver at Epoch, how do they view these things? How do they take it? How do they convince from curative to palliative care, that transition? How do they go from advanced care to the care that you want to give? How do you convince them, and what impact does it have on the caregiver themselves? How well are they able to take it?
So no one is ready to listen to this news. No, everyone dreads that phone call that nothing can be done, because it's human nature to have hope. So even if someone, we have had elders with active chemo and we assist them in their chemo cycles and radiations and all of that. So we know that it is terminal in nature, and this is something which is very, cancer is something which is expected. But something like dementia, you don't tie it to palliative care at all, or any neurodegenerative condition for that matter. So you don't know, there's no awareness. You don't even understand how staging happens. So when, let's say, in a dementia, we use a 7-stage framework. So you are at a stage 6 when your physical modalities start compromising, your bowel and bladder control, and you're completely immobile. All of that happens. You're on a enteral feed that has come in. So that's when, so we do quarterly reviews with families, because they need to be explained what we are doing, because it's an assumption that people think that, okay, if someone's parent is in a care home, they're not concerned. But we have experienced quite the opposite. So they are very, very involved, and it's our responsibility to keep them very informed. So when we explain to them, we explain, so there is a SOP through which, or a framework through which you move from curative to palliative. And obviously one of them is the fact that you don't see any progress. You've tried everything else and there is no progress. They are not responding to a treatment. And our doctors, the facility physicians that we work with, it has to come from them first, obviously. And they need to explain that it's best to now focus on quality of life. And a lot of people are open to it. But there are still some people who focus on longevity, because it is difficult. It's easy for us to say that, hey, look, what is it? But I have seen families become very emotional that no, at whatever cost, for me, longevity is more important. So that's where you need to sometimes come in and advocate for the elder, that if your mom could speak, if your dad could speak, what do you think they would have wanted? It's not about you, it's about them. So that's the hard conversation that needs to happen. And sometimes family members are like, can we take them home? And that's completely fine with us. And we would, help them with a caregiver, etc. But it's difficult. It's difficult because the care at that stage is pretty intense. So it's not that if you're not doing an intervention, doesn't mean that it's easy. All the things that Dr. Mathews mentioned, especially, things, it's, what is it? I mean, it's pain. Apart from pain and medical things, you have to look at, important things like, let's say, skin. You have to make sure they're hydrated, nutrition and all of that, catheter care. You have to ensure that, they're groomed well. So there is a thing called quality of death as much as quality of life. And one of the metrics, by the way, is, did you pass away alone? So when we identify someone, and after the palliative care, also there is a stage when the team now knows that maybe it's also a matter of days. We always ensure that someone is in the room. Because if you ask anyone over here, there is a vision that all of us have, that how do you want to pass away? Each one of you will have an answer to that. And that is not alone, that is not with machines, that is not in pain, etc., etc. And it is, as healthcare providers, as long-term, whoever runs long-term institutional setups or is doing home care, hospice, we must know the answer to that. I feel it's incomplete if we assume how did you want to pass away. So we should know that answer and assist the caregiver in counseling them, they will feel better when they know that they are doing everything possible. I think that's how we handle it with the caregivers.
And do you experience caregiver burnout?
Absolutely. There are times when, and professional caregiver burnout is as, I mean, of course, I'm not even talking about family caregivers who really, really struggle. But even as professionals, we have the caregivers or the GDAs on the ground. They're young girls and boys. They have probably formed a relationship with an elder for the last 5 years, because that particular elder with dementia would not have done activities with anyone else or taken food from anyone else. So yes, there is a counseling that we do. We take them off duty for a few days if required and so on. But that acknowledgement is important.
Fantastic. Thank you, Neha. Dr. Dhvani, moving on to legal things again. I know you told us that it's legal to get an AMD and a DNR, but what are the grey areas that still exist and the work that needs to be done going forward?
Yes, I mean, there are a lot of gray areas, and I don't have the answers to them myself. And as you said, I think clarifying those is the most important. I think the primary one, though, is to devise a procedure that works for all the kinds of settings that we've spoken about. So, for example, assembling 6 doctors in a tertiary hospital in a metropolis may be feasible, although of course there is resistance from doctors even about that, because decisions about whether to intubate, whether to provide dialysis, whether to do CPR, some of them have to be taken in a matter of hours. You don't have the luxury of getting together so many people to decide something like this. So but even then, let's say that this process is somewhat workable in this kind of a setting. But what about the community setting that we've just been speaking about, which Dr. Rajgopal spoke about, which Dr. Mathews has been highlighting as the backbone of palliative care? Now, or even the kind of situation that Neha mentioned, where in an epoch when you are signing a DNR will you be able to bring together these 6 medical experts who will say, yes, this person is terminally ill, now it doesn't make sense to provide him with CPR, let's now allow you to sign a DNR order? Or where in the community will you be able to assemble this kind of expertise for this kind of process? So I think there needs to be and this is the struggle that I constantly face, because part of my job is to try to make this process work in whatever way it can, wherever it can, because it's currently the best that we have. But the other part of my job is to constantly be thinking about where it doesn't work and what needs to be done to the legal framework to change it. Now, this is a very slow process, and I think at the first step, it needs acknowledgement that this process doesn't apply in all kinds of settings, and then it requires, consensus building and the creation of a protocol that will be applicable, and slowly maybe get this. Unfortunately, again, because this is already something that is part of the law, the change will also have to come through either a legislative process or a judicial process, and that is a very lengthy one. But this is, I think, clarifying this process is the first step that needs to be taken towards eliminating some of these gray areas, because if this is done, then all these residuary questions that we have, oh, can I, does this apply at home? Does this apply in a hospice? What do I do when someone comes with DNR tattooed on their chest in an emergency room? All of these will be answered if we have the basics of this process right.
Yeah, and please continue to be the warrior for this for us. We really need you on this. Okay, we have down to the last 7 minutes. Are there any audience questions? Oh, quick hand going up. All right, fantastic.
This was quite intense, to be honest. Not taking it away from the rest of the sessions, but this was quite at the next level. I come from a background where I'm predisposed to cancer. 66% incidence at my parents' level, 75% incidence at my cousins' level, senior cousins. And I've been a community builder pretty much all my life. And somebody spoke about community, Dr. Rajgopal touched upon community. and there was this thing about emotional well-being, emotional therapy, emotional suffering, and emotional therapy. So I'm putting myself at the center of this as a community builder myself, and somebody who's predisposed to this, going into the future. I'm putting myself at the center of this, and I'm just trying to imagine how would I be able to do my job as a community.
How would you be able to do your job as a community when you are bothered by so many thoughts that's running around you? There's a cancer fear that is there, there's a legal issue that's there. How will the community worker mentally prepare for this? Is that the question?
Yes, as a community builder, I'll be interested to prepare myself at this stage.
Right. So that's the question coming to you, Dr. Mathews. When, again,
Didn't make it.
yeah. So the question is, when you go to the community person and tell him, hey, you have to be a caregiver for somebody, I know you already said that they are generally willing to help. How do they mentally prepare themselves? How do they get ready? I mean, it could be a question that both of you can answer, Neha and Dr. Mathews. What goes through the minds of the community worker, and how do you say these are the things you need to expect and get ready for? Is there any sort of a program where you do community training?
We have a training for the volunteers. Anybody who want to support, who are supporting the patients in their area, who want to support, can undergo the training. It's a 3 days training. The first day is about the palliative care, communication skills, etc.
No, I'm not coming from the perspective of somebody who is giving care. I'm coming from a perspective of peer-to-peer community. If that is what community building is about, in palliative, in a community setting, in a hospice or any Epoch center, or from that perspective, not from a what you do, Dr. Mathews, with your
So
community.
the doctor is saying that they train the community worker to do it, but you're saying about how to build a community, how to go around getting
Peer-to-peer.
gathering together and saying, hey,
Peer-to-peer.
let's all work towards palliative care. Is that the question?
As a cancer, somebody is in
risk.
terminal cancer myself.
Right. How do you help build a community for this?
For yourself, you will have to build a community. That's what you
In
are.
the center of it.
Yes. How to build a community of like-minded people who want to support palliative care. How to get them to work together. And also have cancers.
Yes,
Okay.
I am.
And be survivors. I think Nidhi, if she was there, she would have answered
Very
how
tough.
cancer survivors are coming together. So I'll answer that. So Silver Talkies, when I work with them, there are cancer survivors who are also part of that Silver Talkies group. Silver Talkies group is a group for people above 60 years of age, a community coming together and supporting each other, not only through the recovery, but also through general aging activities, bringing back the quality of life and so on, right? As somebody who survived cancer, the biggest fear is one is relapse. The second is, can I live my life normally again? And that comes like you see children when they learn from each other in play groups. This also works like that. And it works not only for cancer survivors, it works for Alcoholics Anonymous, also works on the same principle. You're sharing your story and telling, I am looking forward to life now. And then the same person, some get inspired, some tell you, I've already been on the journey, welcome aboard, right? So that's how the peer-to-peer community of somebody stricken by something and then recovering works. But if you're talking about a community that's not stricken by it, then that's a different deal. That's being more social. Okay, yeah. All right, next question. No more questions. Sorry, that was a long-winded answer. Yes, we've got a hand going up here.
So I think every palliative person like who is in that program, they're looking forward to that humane touch when that ASA worker comes or the specialist that you have trained. I think they would be anticipating to meet that person, right? But as a technologist, I was thinking like today we use all these voice bots and these bots to kind of do loan recoveries because people forget to pay their EMIs on time. So can these sort of technologies help to still build that, let's say, hope on a regular basis that they're not waiting for those kind of, let's say, moments of truth, but technology is enabling those kind of experiences.
So can we create interactions which are not human dependent that allow them to feel the same way? Is that possible?
I may have an answer which you might not like, but I feel that there's just too much focus on technology solving for everything. I think I have the right to die with a human next to me and not a technology. We are not in Japan, we are in India. And people are not a problem. So why are we trying to solve for it? Yes, Japan doesn't have a choice. So by choice, I would not. The answer to your question is yes, of course, we can build. Other countries like the Scandinavian and the Japanese communities don't have a choice. But I would not really advise that in India.
Today morning also, the one speaker on technology said that two things that cannot technology contribute is care and empathy. Two things technology cannot contribute much is care and empathy. But what we think is care and empathy is not a, it can be built up in a person. For that, the person should have chance to see what is happening in the community, what is the suffering in the community, how it can be addressed. They should have a chance to see it. We are focusing very much on research, we are focusing very much on survey, but we are not focusing improving the skills and attitude of persons in providing this care and empathy. That also has to be built up. So we are doing, in the palliative training, we are mainly focusing on that. We are training doctors, we are training nurses, community nurses, volunteers, ASHA workers. In all that, we are teaching, we are training them to for having empathy and care. We are taking them along with the home care team so that they can see patients, how these patients are being cared, how it is beneficial to them. So that, like that, all who participates in this home care program, it improves their skills of empathy and care.
Fantastic. So technology may have a role, but we cannot sacrifice care and empathy. That is the important message. All right. I think the time's up for us. And so I'm going to thank all the fantastic panelists for the amazing work that you're doing. It's a very difficult topic. I would love to be a Neeraj and very casually discuss this, but it wouldn't do justice to the topic. I am amazed by the work that you're all doing in a very, very difficult area where human emotions are all over the place. So hats off to you and thank you for sharing from your experience. God bless you. Big round of applause, please.